Hey, welcome everyone. This is Steve Bell with the MedTech Mavericks podcast. And today I am honored to be joined by Mohammad Ramadan, who we got to know each other a couple of weeks ago. So, hey, great to have you here.
Thanks for having me, Steve. I'm really excited to be here, especially across so many time zones.
Brilliant. Well, no, and thank you for putting me in your schedule. I know you've got surgery today. So, do you want to give us a little bit of your background, just who you are, what you do?
Sure. My name is Mohammad Ramadan. I'm a urologist here in Oklahoma City. I've been practicing since I finished fellowship in 2016. I do general urology, but I did do a fellowship in urologic oncology and robotic surgery. And That's been a big focus of what I do.
The reason why we're having this conversation is I put out an article, what, a couple of weeks ago, probably,
Yeah.
about single port. And you very kindly contacted me and said, I think some things are right, what you say, Steve, but maybe some things you've not quite understood. And we had a conversation, and I just wished I'd hit the record button at the time. I sort of said at the end of the conversation. So give a bit of your background on the SP, and then we'll get into that.
So robotic surgery has been a passion of mine since I started, and offering patients minimally invasive surgery has been an obvious changer over the last several decades in medicine. I have an engineering background from college. I never worked as an engineer, but that certainly it certainly played into how interested I am and how fascinated I am about more minimally invasive approaches. So I saw the SP at an intuitive conference back in like 2017, and it was just about to get launched. And I looked at it and I was like, that looks amazing. And I never really got to get my hands on it to work with it until 2022. But I had been trying for a while. But our hospital that I work at now, here in Oklahoma City, got the machine for us in March of 2022. We did our first cases in April, and I could see an immediate impact on patients, especially as the urology community started coming together and started learning how to do surgery with the single port robot. And as you mentioned earlier, your post online, I don't think many people clicked and read just your first brief paragraph on there because it really said this is clickbait. You had a negative outlook on SP, but it said this is clickbait. I want to bring people together and talk about this. But every response underneath was just like, "Oh, you're right. SP is no good. You can't use it for anything. There's no point to this whole thing." And I thought, I don't know any of these names, and I know most of the people who are heavy SP users now. So it just struck me that no one had responded, or very few people, only a couple had responded that had any significant SP experience. And I know that once you get to use it and once you experience the difference it can be, it's really undeniable what difference it makes to patient care.
I think, and again, part of my genesis of that article was, I hear a lot of negativity or people say, oh, I just don't see the point. It's crazy. And they always refer back to the single incision laparoscopic surgery or SILS, which was a way that people did it in the past. And, sticking a big trocar through the umbilicus just to a lot of people has no sense, right? So that's kind of where I think a lot of those comments originate from, people who've not used it. And what I was fascinated about was, our discussion on the way that you use it is very important, and maybe people are not thinking about this the right way. So what I'd love, the piece that sort of grabbed me of our conversation was what you use it for and how you use it, because I think that was the click in my head where I said, okay, that's got sense. So do you want to explain a little bit about that?
I don't really use it for transperitoneal surgery right now. You can, and there are good applications for it, but where I've found excellent application and really benefit is being outside of the peritoneum. So being in the retroperitoneum, doing kidney, adrenal, ureteral work, or being in the extraperitoneal space, so doing prostate, lymph node dissections, and then things we just can't do very well on multi-port, like being in the bladder, so transvesical access, actually docking the system directly into the bladder, filling the bladder with air and nothing else. So really, we avoid pneumoperitoneum altogether. Uh,
And and, and so you talk about the retroperitoneal. I think that's an important piece that we were discussing, which is you're not breaching the peritoneum. But what was really fascinating to me was your access site, where you access and how you get access, because people worry, oh, I've got a big 4 centimeter hole that I'm going to leave behind. That's just going to be a huge hernia of the future.
So our access into the retroperitoneum has gone through a lot of name changes. The community has settled on low anterior access, and you can put supine onto that. So the patient is actually laying flat, maybe slightly tilted toward, up on the side that you'll be operating on. We're just inside of the anterior superior iliac spine. So people are feeling just inside that bone on the front lateral side of their hip. We're just inside of that, and we're going through the oblique muscles on the sides, but we don't cut any muscles. We just open the initial layer of fascia, then we go through the three layers, external oblique, internal oblique, transversus abdominis, straight into the retroperitoneum. All of those are muscle splitting or muscle sparing dissection. And so when you're done, after you're done with your surgery, um, those layers come right back together. It's just like opening like a window like this, and then you just close your fascia. Since you're not, as you said, breaching or not crossing the peritoneum, the risk of hernia really is almost nil. And it's a much faster recovery for the patient. It's really hard to articulate that until you just see patients face to face. When you see them a few hours after surgery, or you see them the day after surgery or the week after surgery, and they're just ready to go and do more, and they're like, do I really have to wait another week? And really, that's almost impressive in and of itself to say, because in general, when we're doing these operations and you have an extraction incision that may be 3, 4, 5 centimeters or bigger, say you're taking out an entire kidney, you're talking about a 4 to 6 week recovery to prevent having a hernia. Now that's like 2 weeks.
I mean, you've used the multi-ports in the past. You've moved over to the single port now, and you're seeing quite a difference in the post-operative course of the patients in terms of pain, recovery, return to work.
Huge difference. And they're asking to go home earlier and earlier. So we send a lot of people home same day, very safely. There are even patients who sometimes it's late in the day, or sometimes for whatever reason, I said, I think we need to stay overnight. And a few hours later, they say, I feel fine. And I say, the only thing I'm going to do for you tomorrow is get labs. If you're willing to go to a local lab so that I can see how things look tomorrow, and we call you and check in on you, you can go home. And they say, great, send me home. And that's just not something I experienced very often on multi-port. And it's common with single port.
And what do you attribute that to? I mean, you can think about things like insuflating the abdomen. There could be, people talk about pain receptors within the peritoneum. What do you think is making the difference here?
I never attributed that there would be pain receptors in the peritoneum, but now I do believe there certainly are. I think the pneumoperitoneum, insulating the abdomen, makes a difference. I think that we operate at lower pressures on single port system than we ever did before. Now, I know a few people operate at very low pressures transperitoneal, but the typical surgeon operates at 15 millimeters of mercury. Some people will operate at 12 or 10. We typically operate at 10 millimeters of mercury or less when we're in the retroperitoneum or the extraperitoneal space. You're not insufflating the entire abdomen, and then you're also making a surgical incision of the fascia. You're not stabbing a
Mm.
trocar across the fascia. So I think that makes a difference as well.
And so there's different ways you can use the single port. You can use just the pure sort of trocar approach, and then there's also the access kit, and then sometimes you're putting ancillary. What's kind of your method that you use mainly?
Almost always just the access port. And the other part of that is when you're doing multi-port surgery, you have a metal trocar across the fascia, and unless you're in the exact perfect spot, the remote center at the fascial wall, that fulcrum across the abdominal wall, you can cause some mobility and possibly trauma to the fascia and the peritoneum there, which can be uncomfortable. When we put in the access port, it's just an Alexis wound retractor, really. If you think about it, it's just a little plastic ring and plastic that goes through there. So it's soft against the
Mm.
tissues. It's not hard against the tissues. And I started thinking about this more and more during our conversation. And I had thought about the peritoneum and the metal trocar. But more and more, I thought what we have in there is soft. It's not hard. It's very mobile, and it's less. It's just less pressure on the tissues.
So what percentage of yours are you doing exclusively SP, or are you still doing a little bit of multi-port for
Still
different
do some
things?
multi-port, and then we talk about this a lot. It's the right tool for the right patient, but I'm about 90% single port. And so my practice has matured that I can do that. Not everything can be done single port. In the beginning, a lot of people talked about, oh, the single port can do a few things and the multi-port can do everything.
Yeah.
But now we see things that you can do with a single port system that the multi-port system just can't do. So we're starting to appreciate that there's a balance, and it's not one or the other, one versus the other. It's just that you have two tools now rather than one tool. One, I believe, can be less invasive, but it's not suited for absolutely everything.
I think that's interesting. I think again, you refer back to some of the negative comments. Often as humans, we think very much, everything's black and white, right? So if I have a single port, then what am I going to do about my multi-port cases? I think what what made me think a lot when we had our conversation was when you said, you use both. It's the right tool for the right job at the right time for the right patient, which I think is important. A lot of people would turn around and say, oh, but the administration is going to go crazy. Now we've got two expensive systems. I mean, how was that embraced by your administration at the time?
They didn't quite understand it when we started, but and a lot of people didn't quite understand it first because we hadn't figured it out. I anticipated that it was going to be a big part of what we were doing surgically and urologically, and I said we're going to be 2 to 3 years ahead of our market, and that's going to be the benefit to them. We'll figure it out and we'll get really good at it, and then we'll be able to say, look, we're the market leaders here. I think that resonated.
Okay,
um, I try to take back patient experience to our administration all the time, and they're very positive in hearing that news. So we're all patients. I tell people that all the time. We're all patients at some point. So I come back to them and I say, let me tell you about this patient that had this problem and we took care of it in this way. And we couldn't have taken care of it in another way, or it would have been much more invasive. And they understand that because I see a lot of people who are, employees or people's, loved ones. And once you experience that and you say, I can do something for you and you recover faster, everyone says, well, we want that. Why wouldn't you take that? If I can do the same operation, same, if it's, we do a lot of oncology, same oncologic outcome and just be less invasive and have a faster recovery, who's going to turn that down?
sure. No, I agree. And is your hospital, do they sort of market that as well? Is that something that they go out and market that, you've got the optional, either multi-port or single port as minimally invasive? Has that got down to the patients yet?
We've marketed some. I'd like to market more, but they have done a little bit of marketing around.
When you sit with a patient and you explain the differences in their procedure, do they kind of get it? Does it sort of make sense to the patients when they hear that?
When I first started, I explained it to them a lot, and I offered them multi-port or single port, and I explained to them that these were going to be the first single port cases in the state of Oklahoma, and that they were going to be my first single port cases. Although it was going to be the same operation, so several of my first patients were radical prostatectomy patients, and I said I can do this the way I've always done it, multi-port, the way almost everybody does it, or I have this new system we can do it single port. In the end, after the conversation, the patient just said, you're the surgeon. You choose whatever you think is the best thing for me. So we've decided on the surgery. We're not going to tell
Okay.
you how to do it. You
Okay.
decide how you're going to do it. Since that time, since my practice has become primarily single port for these cases, I just tell them it's going to be robotic assisted surgery. I tell them they're going to have a single incision. Sometimes they'll have a extra incision, which we call a plus one, an assisted incision. And that's just what we're going to do. Some patients will come and ask about single port versus multi-port. They'll ask about approach. I had a patient, excuse me, the other day. I had a patient come the other day and he asked, he left and he sent a message back and he said, I think I need to go to a specialty clinic in Florida that only does adrenal gland removal. They do it outside of the peritoneum and they do it through the back. And can you do that? So I called him and I said, I think it's just easier for me to tell you in a few minutes over the phone than write a long email. He wrote a long, long message to my chart. And I said, your surgery will not be through your back. And in fact, that is a little more uncomfortable for you, the way they do that retroperitoneoscopically. Amazing surgery. But it's a little uncomfortable. I said, you'll have a single incision. It'll be retroperitoneal outside of the peritoneum. And we'll do all of the things they were going to do, but probably in a softer way for you. And he said, great, then I don't have to go to Florida. We
You
do
know,
that for you.
the incision you keep talking about always keeps coming back to me. It's kind of like sort of in the Phalansteal area where for a long time, people have been doing these umbilical approaches. I think there's something in that for not just for I think even for some of the transperitoneal, the approach that you're using there, I think it has merit in other surgeries beyond just urology. I think for a lot of the gynecological procedures, I think there could be some big merit in doing that. I don't know whether your colleagues have or are using it for other things than urology.
So the pelvic approach, I do pretty much a phalansteal incision. It's a small, 4 centimeter usually infra-umbilical incision. I do make it horizontal through the skin and the fascia, and then I spread the muscles in the midline. Um, there are approaches, and there are some of my colleagues who've used that transperitoneal to access the kidney. So if they're working on both kidneys, they'll access through a phalansteal incision. So there are some really novel things you can do for it. I had a surgeon I operated on, and he came back the next week, and he looked very confused, and he just said, "I just don't understand why there's no pain at my incision." He said,
Mm,
"I haven't had pain," and he operated on people for 40 years. So it that was very powerful to hear that from him because he had a lot of experience with this. He has a
yeah.
completely different context than the average patient.
Yes.
But that small infraumbilical incision he had, that phalansteal incision he had no pain from. And so that was another aha moment.
Yeah. And a lot of robotics is about the surgeons, um, but it's also a lot about the OR staff. How have they adapted? You'll have had OR staff that were used to the multi-port and now gone to the single port. What's kind of their interpretation of this?
I actually responded to like a LinkedIn question quite a while back that had this to do with it. It asked about change. How do you work with change with your team? And so um, really, there's a lot of negative inertia around change in the operating room, and with good reason. So if you have something that works in a high stakes environment and you're doing really well at it, it's like airplanes, it's like flying. There can be zero mistakes, right? Um, so people don't want to change if you have a system that works. So when we first started, there was a lot of skepticism, and some of our cases took a little longer. And that's true of any change in
Sure.
modality, open to lap, lap to robotics, multi-port to single port. And at first, they said, you know what, we could have been done a little bit earlier. Why do you do this? And I went over it with them a few times. And every couple of weeks, I take something back to them. While we're operating on Mondays, I say, hey, you remember that patient from a couple of weeks ago? Remember that difficult, case we had or the difficult scenario we had? That patient's doing great. Or here's the outcome. Or we have patients that come in who have hostile abdomens, and everybody looks at their abdomen once we're getting them prepped, and they say, man, this is going to be hard. And I remind them, I don't think it will be hard because that was all transperitoneal.
Yes.
We're going to be retroperitoneal. And we had a patient the other day, a large patient with a large colostomy with a huge hernia, a massive peristomal hernia. And my nurse was like, oh gosh, they have a colostomy. We know this is going to be difficult. And I said, just remember, we're not going to be around that colostomy. We're going to push this to the side and we're going to do retroperitoneal surgery. And it was completely routine. There was nothing different about that patient than a patient that was thin with an abdomen without any prior surgery. That that's very special
Yeah.
to take a patient who you would usually come in and say, look, because of your prior surgeries, because of this hernia, because of your colostomy, we're operating on your left kidney. this is going to make this surgery more difficult and more risk for you. That would be the usual transperitoneal conversation. Higher risk of bowel injury, higher risk of bowel complications, potentially longer surgery. I didn't have to have that conversation with her. I said, we're going to make this go to the side and we'll stay away from the problem area and we'll do a routine operation for you. And it was exactly that.
Wow. Wow. And you talked a little bit there about change and like when you change from one aircraft to another. You know, some people might get lulled into the sense that, if you're going to drive the SP, it's like exactly like driving the XI. What was your learning curve sort of through the different way that the instruments move versus, like an XI to an SP?
When I was learning it, there was an extra cognitive load. And I really thought that it was probably easier to teach this to someone new than it is to teach it to someone who has a lot of multi-port experience.
Mm.
Just like technology through generations, kids pick up things so much faster technologically, than we do, but they don't have biases from doing things old ways. So I had to free my mind of the endorist. The endorist is how almost all the multi-port systems work, and it's a fascinating, unbelievable technological achievement. You actually have more strength and more range of motion than your hand, and our hands are marvels in and of themselves. The SP instruments have what they call a joggle. It's more of a shoulder elbow rather than a wrist.
Okay.
And you had to get used to that a little bit. There have been upgrades of the instruments over the years, and there's a brand new upgrade coming now where you have increased what they call wrist angle and motion, but also a larger working space because the joggle is wider rather than closer. So you have different options. But it did take a while to get used to it. The hardest part of getting used to it was suturing. The scissor motions, the dissection motion, that was fine. With the robotic instruments, I can get my hands in the angles where they need to be. But not having that endo wrist suture took some muscle memory change. Once you changed it, which was just experience over time, practice, it's just muscle memory at that point, and I don't even think about it anymore. And
Okay.
it was, within the first year that I stopped thinking about it. I stopped thinking, oh, I have to adjust. This is just harder than the endo wrist. After a while, you just learn to do it, and it was fine.
And I think that's, having been on the commercial side of selling robots, I think that's one of the dangers of somebody rocking up at a Congress, sitting down on the SP who's got, 8 years of XI experience and having a go and saying, yeah, it doesn't work as good. Okay. I think what you raise there is if people can get their heads around the utility of the SP and having it in the right procedures for the right things, I think they've got to put a little bit of work in and just accept that there is going to be that difference. Because I think if they just expect it's going to be the same as the XI, I think there might be disappointment. And I think some of the negative comments, maybe people who've not used it for like a year in the operating room, but have sat on a Congress and sort of used it and said, "Meh, don't get it." What do you think?
100%. When I tell people they're starting, I say, look, I want you to focus on getting on the system at least once a week. Try to move once a week, one case a week over at least. If they do that, everyone I've spoken to has progressed to where they've done more and more cases that way. So it's a progression that you need to have. And what's interesting to me and almost a little bit funny, it's the same argument on change of technology over the years. It's the same, just as we said before, it's for the same from open to lap to robotics. And it's those same people who went through a technologic change during their careers, but now resist it. And I'm sure it'll be me in the future. It just seems to be the way things go. There'll be something that comes out later, and I say, nope, you can't get better than Singapore. Um, but it's just practice and getting on it and being open to it. It's also different today than it was. When they launched in 2018, they didn't have a lot of the advances that we have today. They didn't have the access port. They didn't have the now, twice upgraded instruments. Um, They didn't have, I'm not sure they had a clip applier at that time. So there were just things that make it easier today than it was then.
And
And
they
they didn't
just
have the,
they just launched a stapler. I think 2 or 3 days ago they
it
launched the
just got approved. It
yeah
just
just
got approved. So hopefully we'll be using that, this summer.
yeah
And that will be another game changer that you're able to do everything through the same port and you're not reliant on an assistant if you don't need to be.
perfect. Hey, look, I know we're up on the half hour, and I know you've got surgery today, so I just thought this was a fascinating conversation. I'm so glad we got to record it this time because I think. I probably came from a little bit of a biased view because I saw the sufferance of SILS, the single incision laparoscopic surgery in the day. And I think our conversation has certainly opened my mind a little bit to the SP. So I thank you for that. And hopefully, people who are watching this, if they want to reach out to you and get hold of you, what's the best way? LinkedIn or how can they get hold of you if they want to talk more?
I'm on LinkedIn. I'm on X. I'll share my email with you, my professional
Yep,
email. If
I'll put
some
it on the
people
screen. Yeah.
reach out to me, I'd be happy to talk, and maybe we can have a follow-up conversation. I'd be happy to discuss with people who have had negative experience or no experience. It's and the biggest thing to me and telling people they keep coming back, why should I change? And there's a lot of people who have they're ready with reasons not to. If I
Yeah.
say, here is what the reasons were for me, and we discuss those, but I do this, but I do this. And I say, I'm not asking you or forcing you to change. It's totally up to you. The difference is I see a difference in patient care.
Yeah.
I see a difference in what I can offer to people who would otherwise be complex surgeries for other surgeons going through a transperitoneal approach. That is a lot of benefit to me. I ask myself and I ask my team routinely while we're operating, hey, if you had this problem, what would you choose? It's unanimous. Every few months or twice a year, something like that, I ask them, it's unanimous in the operating room. We would have it done this way.
Wow.
That means a lot from people watching surgery day in and day out.
Powerful, powerful. Well, look, thank you very much. That's been absolutely brilliant, and I'm so glad we got to record it this time. Thank you for agreeing to come on after we'd already talked last time and didn't record it.
Yeah, absolutely. It's been a lot of
So,
fun.
so great, and have an awesome day, and hopefully people reach out to you.
Okay. Thanks, Steve. Take care.